patient, we now want to put you on 6 months of chemotherapy. But why, doctor? You took both my breasts. Well, we just want to make sure that there's no recurrence. So you now undergo 6 months, 8 months, depends. Remember, we've got our conventional first-line therapy telling us what to do, and we cannot wander from that. So now you've lost your breast, there's psychological issues, there's physiological issues. You're now going through this whole paradigm shift. You're taking chemotherapy, depending on what it is, you start losing your hair. All the classic characteristics of an active chemotherapeutic regimen. 6 months goes by. Well, as a precaution, maybe you should undergo radiation. Does insurance pay for it? Yes. Okay. Now, doctor, what does that mean? Well, patient, that means that we're going to give you 25 fractions of radiation. What does that mean? A fraction is a session. So that means 25 times over the course of the next 3 months, you're going to visit me and we're going to radiate. It's called the tumor field. We're going to radiate the entire tumor field. And we're going to give you about 2 to 2.5 gray per fraction. Well, doctor, what does gray mean? The gray is the amount of radon that we're going to give you per session. So at the end of the 25 fractions or sessions, it'll be approximately 50 to 60 gray. Okay. Will there be any collateral damage? Well, yeah, there'll probably be some collateral. There'll be some side effects, maybe some leathery skin, maybe some ulcerations, etc. But we think you should do this. Okay. Now you've undergone bilateral mastectomies. You've undergone 6 months of chemotherapy. You've undergone 2 months of radiation. It's taken about a year. And you so hope that it's over and that never again will there be recurrence. Well, the fact that you had the biopsy unprotected, the fact that you've now lost your breast, the fact that you've undergone chemotherapy, the fact that you've undergone radiation, your body, your natural immune system has been just beaten up. So you go to your doctor. Say, doctor, I am a beaten woman. I am a beaten patient. I've lost weight. My nutrition has been influenced. What do you do? Well, that's not really my specialty. I think you should go to a nutritionist or someone that can help you. And they're pretty much done with you. Now, how would we treat, we being ICCA, how would we treat an early stage breast patient? Number one, we would schedule an appointment, and through palpation and at our clinic, we would do an ultrasound. We'd confirm there's a lump. And then we would say, okay, we don't think you're partially pregnant. We think you're pregnant. All the signs, the markers, et cetera, suggest that it's a malignant cancer. So we're going to do what's called an aspirated fine needle biopsy. But before we do that, we're going to inject, remember, 1 hour before the procedure with the chemotherapy. Then what we're going to do is 10 days, 10 fractions of short course radiation of 2 grays to 3 grays per day for 10 days for a total of 30 gray, not the conventional 50 to 60 gray. This ensures there is absolutely no collateral damage. But to increase the efficacy, as if you had undergone 30 fractions, we give what's called a chemosensitizing agent. So on Wednesday of the first week, we give you a shot of chemo, just a shot. And in the Wednesday of the second week, we give a shot of chemo, so that synergistically, although we only give 30 gray of radiation, the biological effect is 60 gray. And you've avoided 15 fractions. So look, the question that begs to be asked, why would you take a 24-inch skillet to cook a 3-inch egg when you could have just as easily used a 6-inch skillet? Why? It's because the clinical trials and because of the manufacturer that manufactures the radiation equipment sets it up that way. And this poor doctor in Sioux Falls or Chicago or Miami can only follow the rules. We can't, because we purposely practice in Mexico, 20 minutes from the US border. There, we don't have to follow NCCN guidelines. We don't have to follow conventional therapies, etc. So radiation is significantly different. Now, let's get back to the patient that underwent the bilateral mastectomies. So now, we've done the protected biopsy. We've done the 10 days of radiation. On the third day of commencing treatment, we administer what's called a bispecific EpCAM/CD3 vaccine, aka antibody.
If I can actually, because that's a very important topic that I would like to go more in detail. And, it's really helpful how you are making the whole case flow of a comparison between the patient visiting traditional cancer centers and ICC Global. And I think it really explains that, and obviously patients are not trained clinically. They rely on doctors, and especially with these conditions like that, when they get diagnosed, you really are mentally switched off, right? So you just follow the direction what the traditionally to the is given to you, especially your physician. And physicians get restricted based on the geography they are in, based on the regulations they are in. So having something which is, cross-border, but giving without restriction, more innovative approach to the traditional treatment, I think that's what makes ICC Global stand out. And also I like, as a non-physician, how you really entered into this complex, very critical, very challenging, but at the same time, very needed, area in medicine. Cancer is something affecting, it's the second leading cause of death. And every year there are 20 million new cases of cancer, around the world. It's a big number. Having approach like yours that you are doing at ICC Global is really innovative, because you're keeping patient first and then other things around it, and not the other way. So I clearly see the difference, how ICC operate different from a traditional chemo center, and how your approach is more biological and not just clinical. Before we go into your vaccine program, I know that you have a very innovative and a distinctive program called FivePoint Cancer Program.